Today's presentation will be on ocular toxoplasmosis, which, as everyone knows, is the most common posterior uveitis, the most common infectious uveitis. So we're going through some various presentations of this. I'll be monitoring the chat throughout the talk. So if anybody has any questions, please post them in the chat box and we can address them. We obviously want to make this as interactive as possible. So we'll start by going through the objectives. So to recognize both the classic and the atypical appearances of ocular toxoplasmosis and be able to differentiate them from mimickers of it. Diagnose using clinical findings, imaging modalities, and laboratory testing, and how to effectively treat them with antimicrobial therapy, when to use steroids, and any adjuvant options. So we'll start off with Heba, who's going to give us the first case, and followed by Yusuf.
Hi, I'm Heba. I'm a PGY2. So I'll start with our first case. It's a 23-year-old male. He was referred for panuveitis. He's had some floaters and a blurry film over his left eye for a couple of weeks. His past ocular history is a family history of retinal detachment. And just on review systems for uveitis, it was remarkable for food poisoning due to undercooked beef recently. His father had history of tuberculosis. He was seen at a different hospital and was started just on Predfort. So he was on that in the left eye. For his clinical exam, his vision was pretty good, 20/20, and he had some mild, very, very mild AC reaction, a little bit of haze. And on exam here, you can see that there is a hypopigmented chorioretinal lesion superiorly, and there's a bit of hyperpigmentation adjacent to it. So pretty classic for toxoplasmosis, and not a lot of haze. You can see a bit of vasculitis adjacent to it, the Kyrilli's plaques next to it over there. So yeah, just as I said, we have a chorioretinal lesion with mild adjacent vascular sheathing, so pretty classic for toxo. So in regards to the diagnostics, just going over everything, we have an IgG and IgM. IgG is for previous infections, and it remains positive for a long period of time, as you can see at the graph below. And then you have an IgM, which indicates an acute infection. It goes up and then it starts to dip down as the infection resolves. And then for an immunocompromised host, it's useful to do toxoplasma PCR, either through VIT or AC tap. And that's useful for immunocompromised hosts because they usually get negative IgG and IgM studies. For us, we kept the workup pretty focused. I did some digging into the case and actually found that he had positive IgM 4 years prior, and he had a huge uveitis workup at the time as well. So I'm assuming that the hyperpigmented area he probably presented and received some form of eye care there or some sort of workup at the time. Okay, so just a reminder, we have a very small chorioretinal lesion away from the 5 disc diameters from the optic nerve, some sheathing adjacent to it, some vasculitis. What would you treat at this point or no? And ask the audience here.
And the poll.
Okay, so a lot of 75% of people said no, 25% said yes. So just going over the treatment criteria or indications for treatment. So anything near the optic nerve or macula that would be threatening the vision, close proximity to the major retinal vessels, which did not apply to our case. Dense vitritis, no, the patient just had like 1+. And marked visual impairment, the patient had 20/20 vision. It wasn't a very large lesion. The patient was a male, wasn't pregnant. Monocular status, the patient wasn't monocular and was not immunocompromised. So just based on, the indications for treatment, the patient didn't fit any criteria for treatment. And so we opted to observe the case, stay on the Predfort for the AC inflammation, and then drop down to QID and give a follow-up in 2 weeks. So we decided to closely observe the patient. At 2-week follow-up, the patient was doing pretty well still. The vitritis was a little bit more, but again, close monitoring. 2 weeks later, the patient's vision was 20/40. The vitritis was a lot more, and there was an area of vitreous traction around the area of the chorioretinitis. The chorioretinitis was actually stable, but the patient was starting to develop a lot of traction there. So based on that, I will ask our audience again, what would you do? So would you start antibiotic treatment, increase the steroids, topical, or would you just closely observe again?
Well,
Okay, so 70% of people said to start antibiotic treatment, which is exactly what we did. So because of the increased vitritis, we opted to treat. Just going over the treatment, we have the classic triple therapy. Some people do an adjunct as with oral clindamycin, and then Septra dual strength is also very, very common. Monotherapy with clinda and azithro have also been described. And then local intravitreal clindamycin with local injection of steroids as well is also an option. And systemic steroids usually are started as well within 72 hours after starting the antibiotic. But in general, there's no consensus regarding the best treatment strategy. Most people just go for the classic triple therapy. So we decided to go for Septra dual strength BID for 4 weeks and PO-PRED after 72 hours with a taper every 5 days. And we decided to also continue on the Predfort, and obviously close observation given the amount of activity that he now has. So we saw him a week later. His vision was count finger, and he has a huge giant retinal tear. MAC was off. So obviously he needed surgical management at this point. He got a pneumatic retinopexy to unfold the retina. His MAC was attached by the next day, but he still had residual fluid. So an additional amount of gas was added. His retina was still attached, but unable to add adequate laser due to the vitritis. So he underwent PPV for this. At 2-week follow-up, his vision was count finger. The view was still hazy, but the retina was attached. And at that point, he'd completed his toxo course. And the main goal now was just to optimize his vision in relation to the complications of, the surgery. So he had a lensectomy, a YAG cap, and an ERM peel. And he still had some mild CME, most likely tractional, maybe inflammatory as well, which was treated topically. So this was what he looked like on 2-week follow-up. You can see that the retina was attached, and the toxo lesion is pretty much undetectable. There's no vasculitis, there's no vitritis. View is pretty much clear. And then here you can see the vision is 20/50 after all of this, the ERM peel, the lensectomy, the YAG cap, everything. And he still had some very, very mild residual CME with an ERM. So just to discuss retinal detachment and toxo. So that's the main sort of twist to our case. The literature, there's not much literature on it. There was a very small study that showed that 6% of toxo cases had retinal detachment compared to 50 to 75% in acute retinal necrosis. So it's quite a rare complication of toxo. And they said the potential risk factors would be the severe vitritis and superior chorioretinal lesion, which fits in our case. Our case had a superior chorioretinal lesion. People sometimes would do a vitrectomy, diagnostic vitrectomy in these cases, and they found that these people who underwent a diagnostic vitrectomy, didn't prevent them from getting an RD. And prophylactic laser retinopexy of the lesions were also not preventative. They still detached. And a lot of them, 50% of them actually, had a vision of less than 2200. So it's a very happy ending that our case ended up with 20/50 vision. Okay, thank you so much.
That was great, Heba. Just one thing I wanted to add was, in terms of the use of adjuvant oral prednisone or systemic corticosteroids, Certainly anything that's involving the macula or threatening the optic disc is an indication. Retinal vasculitis would be an indication, and very severe vitritis precluding the view. Oftentimes, if somebody comes with a peripheral lesion, it could be just treated with topicals and antibiotic therapy. So it's when to use oral steroids. It really depends on the case. In this particular case, interestingly, he kind of grumbled along for about 4 weeks at 20/25 vision. And then when he developed that traction, that's when we treated. But unfortunately, by that point, it was a bit late. So the other thing to always mention when you're observing patients is to explain to them that toxoplasmosis is extremely pro-inflammatory and that they'll oftentimes have floaters and blurred vision for a prolonged period of time, and that if they want to reduce the duration of that, that they can have antibiotic therapy. And so, most patients tend to elect for it at that point. I'd say the majority, even if they don't reach the indications that were stated previously, the majority of patients do choose to have antibiotic therapy. But it's always important to counsel them because I could tell you that rate of allergy for Septra in terms of skin rash and other things can be quite high. I've seen some pretty significant adverse reactions from that with clindamycin, obviously diarrhea, risk for C. diff. So it's important to just have a discussion with the patient about the criteria and give them the opportunity to make the decision based on their personal preference. So the next one, Yusuf, why don't you present the next case?
Panos, can I just ask you a question? First of all, congratulations on a wonderful outcome. I mean, you really saved that eye with some vision. But was there any indication when you saw the traction on the retina? Was there any indication to go in before the actual detachment or try to prevent that from happening?
So that's a great question. I don't think so. And the reason why is, you have a young guy with a very formed vitreous and vitreous traction. I think if you went in there and did a vitrectomy, you'd be very high risk of inducing iatrogenic breaks just because of the appearance. And also, there are people, that have traction and don't develop giant retinal tears. This particular gentleman, interestingly, looking back, his mother had a retinal detachment as well. There might be something there that put him at a little bit higher risk. But I mean, when he first came, he basically didn't think he really had much of a problem because he had been on the prednisolone drops every 2 hours and he was 20/20 vision. So that's the reason why initially we elected to observe, but that's why you followed him closely. And so when this developed, we started him on the treatment, and despite the treatment, he ended up progressing.
Okay, guys, so I'll take it off after Hiba. My name's Yusuf. I'm one of the PGY3s here in Toronto. So case 2 is about a 20-year-old Turkish female who was referred for 3 weeks of vision loss in the right eye only. She did not have any pain, redness, or sensitivity to light. There was no history of floaters, and her review of systems was negative. Her past ocular and medical history was unremarkable, and she was not on any medications. And as I mentioned, she was an international student from Turkey. On exam, the vision in the affected right eye was 20/50, and then the unaffected eye was 20/20. The pressure and the pupils were normal. And the anterior chamber was quiet, no anterior chamber cell, no KPs, no signs of inflammation at all in the anterior segment. On exam in the posterior segment, there was a small white retinal lesion that was about less than half this diameters in size in the inferior macula, with an adjacent pigmented lesion, scar-like lesion just adjacent to it. And then there was also some yellowish material in the macula that resembled somewhat of a macular star. So just highlighting these 2 main findings over here. There was no vitritis, vitreous haze whatsoever, and there was no vasculitis. OCT through the macula showed some hyperreflective material in the Henne's layer in keeping with a macular star, and OCT through the lesion inferior macula demonstrated a primarily outer retinal lesion with its involvement there. So this patient had a unilateral focal outer retinal lesion, a mild neuroretinitis, and no vitritis or vasculitis. And despite the patient not having any vitritis, we did think that this patient had toxoplasmosis with a mild neuroretinitis. Investigations were done, which revealed a positive toxo IgG, and the patient was started on Septra double strength 2 times a day. 2 weeks after starting treatment, the vision was getting better from 20/50 to 20/30 in the affected eye. And you can see a bit of fading around the peripheral edge of the retinal lesion. The macular star had essentially resolved at that point. And then 5 months after presentation, the patient had been seen a few times. Septra was continued at full dosing for a couple months and then dropped down to prophylactic dosing to Monday, Wednesday, Friday. And 5 months later, the vision was 20/20. There was some scarring and pigment changes around the lesion demonstrating inactivity, and the neuroretinitis had resolved again. This is just an OCT macula at the 5-month mark demonstrating the resolution of the macular star, and then just some subtle changes in the outer retina in the right eye. So going back to the case in the discussion, how could this have been toxo if there was no vitritis? You know, Dr. Christakis mentioned that one of the classic key hallmarks of toxo is that headlight in the fog appearance with lots of vitreous inflammation. That's one of the reasons why these patients can actually detach. In 1969, Claude Freeman and David Knox out of Baltimore analyzed 63 cases of toxoplasmosis that were confirmed and characterized them by phenotype. And by far, the majority of cases followed a large destructive phenotype where there was a greater than 1 disc diameter area of retinitis with significant vitreous inflammation. There was also a smaller subset of patients with what they termed punctate intraretinal lesions with small retinal lesions and minimal vitritis. But there were also a smaller number, 11 out of the 63, that had punctate deep retinal lesions, always in the macula and without any vitritis. DOV and Gass described this phenotype as punctate outer retinal toxoplasmosis in 1985, and they termed it PORT for short. And essentially, this phenotype of toxoplasmosis has gray-white lesions at the level of the deep retina without much of a vitreous reaction. There's less inflammation than classic toxoplasmosis, as we mentioned, but because lesions are often in the macula, there's still some vision loss associated. So PORT typically affects younger individuals. There are multiple case series describing this phenomenon in younger individuals. And similar to our case, the patient was 21 years old. It's bilateral in roughly a third of cases and can present with a neuroretinitis, which our patient had. There are often frequent recurrences in the adjacent areas in the macula. The differential diagnosis for PORT really includes anything with outer retinal choroidal lesions without much of a vitritis. And for that reason, white dot syndromes are the main diagnostic entity that comes to mind. On the contrary, for the differential diagnosis for white dot syndromes, it may also be worthwhile to consider PORT as a differential diagnosis too, just because they may present similarly. And then expanding beyond white dot syndromes, of course, inflammatory, neoplastic, and infectious posterior uveitis are also on the differential diagnosis. So still important to consider that full uveitis workup, sarcoid, masquerade syndrome, syphilis, TB, all that shebang. As far as the proposed pathophysiology for PORT variant of toxoplasmosis, this may represent a first-line immunologic defense against the choroidal circulating infectious organism. And this inflammatory cascade is initially confined to the outer retinal layers, typically at the level of the RP and Bruch's complex. So right where that red line is, it's kind of where the PORT variant's inflammation and inflammatory cascade is limited to. But if the deep punctate lesions gain access to the inner retina or become full thickness, then vitritis can occur. So, you know, there's maybe a thought and hypothesis that individuals with PORT toxo, their immune system is a bit better able to control the inflammation. And that may be why we see this case typically in younger individuals as opposed to older individuals, which may have some relative immunocompromisation. To summarize the PORT variant of toxoplasmosis demonstrates outer retinal involvement with little to no vitritis. PORT may have neuroretinitis or optic neuropathy in the same eye, as happened in our case. The differential diagnosis for white dot syndromes includes PORT and also other infectious, neoplastic, and inflammatory uveitis. You can perform serologies, so the IgM and IgG, but the AC-TAP is not likely to be positive just because of that minimal or lack of vitritis. So AC-TAP for toxo is not especially high yield. And then lastly, multimodal imaging with OCT and fundus autofluorescence can aid in differentiating from white dot syndromes and other retinitises. So that's it for case 2.
So that's great, Yusuf. Just one kind of clinical pearl about ordering serologies. Both IgM and IgG will be done by public health, but IgM will only be performed if you specifically write a history that's in keeping with an acute toxoplasmosis presentation. So if you just send it off IgG, IgM, and you write toxochorioretinitis, only the IgG will be performed. So IgM, the microbiologist needs to approve manually, and you need to leave a history. And so you have to explain, this looks like an acute, there's no chorioretinal scar, please perform IgM, very important, because in an acute case, you can oftentimes miss, the IgG will be negative for the first couple of weeks, and then will start to become positive. So during that first 2-week period, it's important to request an IgM, assuming that there's no adjacent chorioretinal scar. Okay, Heba, why don't we go through the third case now?
Okay, so for the third case, we have a 25-year-old African male. He was referred for chorioretinitis in the right eye and some vasculitis also. He had 2 weeks of neck stiffness and some floaters in the right eye. And that's pretty much all he had. His past medical history, he had some bilateral foot lesions. And at that point, he was started on Predfort QID for the uveitis. And for social history, he was moved from Liberia in 2016. So his vision in the affected eye was 20/40. He had monofat KPs. He had a mild AC reaction and some mild haze and vitreous cell. So on the fundus photo, as you can see here, there is a lot of vasculitis, a lot of vascular sheathing, and there is a focal sort of choroidal chorioretinal lesion inferior to the optic disc there. And there's no adjacent hyperpigmented scar that we can detect on this photo. Over here, this is just another photo demonstrating the same thing. Lots of vasculitis here. On OCT, we took an OCT cut of this lesion, and it shows a full thickness, full thickness hyperpigmentation of all the retinal layers representing the lesion there, and a lot of vitritis as well. On IVFA, we can see that there is leakage around the area as well. So overall, we have a unilateral granulomatous panuveitis. So it's considered a chorioretinal granuloma at this point, with a focal choroidal lesion with overlying retinitis and prominent 360-degree sheathing. So our differentials remain broad, right? As I said, the infectious etiologies, toxo is one of them. There's no adjacent scar, but toxo can certainly present this way. Tuberculosis, it could be that focal lesion could be representing some sort of granuloma. Endogenous endophthalmitis, although the patient had a unilateral presentation, but a bacterial infection or endogenous endophthalmitis should always be on the differential. We have sarcoid as well. It's a granulomatous disease, and a solitary choroidal granuloma as well as in the differential. This patient had a comprehensive uveitis workup. It doesn't show on this slide, but basically all of the tests we did, ESR, CRP, C3, C4, lysosome, rheumatoid factor, ANA, double-stranded DNA, everything, all the inflammatory workup came back normal. We did a full infectious workup. TB was negative, syphilis was negative, Lyme was negative, but toxo IgG was positive. Interestingly, IgM was negative. And then he also had a Hep B and Hep C positive also. So at this point, this is a good chance to do an AC tap for this patient, because IgM was negative, but IgG was positive, and we just wanted to rule out toxo because everything else came back negative. So we were sort of writing on that diagnosis, and he was already, we kind of started on the triple therapy also. And 1 week after starting treatment, his vision was 20/20. His KPs completely resolved. He had very, very trace AC cell. Still a little bit of vitritis though. And you can see this was pre-treatment and this was post-treatment. So you can see that the vasculitis had resolved, and the sort of chorioretinal, like focal chorioretinal lesion was also resolving, becoming more flat. I'm showing you the OCT again. You can see the bulk of the lesion, and then here you can see it flattening out 1 week after. And then just a discussion. Now, would you prescribe prednisone for vasculitis and or vitritis? Yeah, just sort of a discussion, no poll here. Just kind of keeping in mind, but for us, we decided to start on prednisone. So you can see here, this is after prednisone. So just giving you a before and after. This was before prednisone, and this is after prednisone. So you can see the remarkable difference in the sheathing. So the sheathing and the vasculitis had completely resolved. And then it also helped with the lesion also. So again, this is baseline. This is after the triple therapy, and this is after the steroids. So really flattened out there, and then the resolution of the vasculitis. So in summary, toxo may have prominent choroidal involvement for sure. And toxoplasmosis may have significant diffuse retinal vasculitis. I know we always say that it was associated with a lesion, but if we go back to the image, we can see that the vasculitis here was actually not super adjacent to the lesion. It was more so around it. And last but not least, steroids definitely may be a useful adjunct for vasculitis, as Dr. Christakis alluded to in our first case. Thank you.
So it's interesting for this case, you know, we say toxoretinal choroiditis, but, you know, sometimes there could be a mostly choroidal involvement, as was in this case, with subsequent retinal involvement. Having a negative IgM obviously was a little bit unusual with an active infection. If you catch it, you know, in the first couple of weeks, which his symptoms had been, you'd expect the IgM to be positive, but the toxo PCR came back positive, so that obviously helped it. What made this a bit more confusing was he had this history of these fungal-like appearing lesions in his feet. He had gotten steroid injections that had gotten better, and the question was whether this might be a fungal etiology. But that retinal that sheathing that he has, diffuse sheathing, is very kind of classic for toxo. And then there's a question from Peter Curtis. There's a question from Dr. Curtis about whether to worry about CNS toxo. That's a great question. I mean, I usually do ask patients about whether they have any type of neurological symptoms. You'd expect, you know, especially in acute cases, you have some type of circulating pathogen that ended up in the choroid. Could they potentially have CNS involvement? In a primary, that is a possibility. I tend to ask for a review of systems, and if they don't have any neurological symptoms, I don't order neuroimaging. But in anybody that's immunocompromised, I would, because, you know, any patient that has HIV or has a significantly reduced immune system, possibly from chemotherapy, and that I would definitely order neuroimaging to rule out if it's an acute. If you have a reactivation, then obviously there's no risk for CNS involvement because it's not a circulating organism, it's a reactivation locally. Okay, and then Yusuf, you can go ahead for the last case.
All right, so guys, this is the last case over here. Case 4 is an 86-year-old Caucasian man who was referred for a bilateral necrotizing retinitis from his ophthalmologist. He complained of a 3-month history of right.
Sorry, Yusuf. I'm just gonna answer. There's just a question from Kenning that I just saw now. It's asking about intravitreal clindamycin and dexamethasone versus oral treatment only. That's a great question. You know, if patients are pregnant, obviously that oftentimes complicates things in terms of antibiotic selection. If it's a primary tox, obviously they need systemic treatment to protect the fetus, and if it's a local reactivation, then it can be treated locally. The nice thing about clindamycin is that it could be, if you give the intravitreal clindamycin, you're getting it on board right away. And dexamethasone has a very short half-life. So unlike triamcinolone, it has a half-life of just a couple of days. So Clind and dexamethasone are particularly helpful in cases in which it's macular optic nerve threatening, and you want to get the treatment in as soon as possible. Also, you're reluctant to start oral steroids without giving antibiotics, 48 to 72 hours to work. The nice thing about an intravitreal dose is that you can give concomitant steroids simply because the penetration is excellent. It's being given locally. And then oftentimes clindamycin can be given intravitreally in addition to systemic antibiotics. So if they're on, let's say, Septra double strength BID, and then you're noticing changes or worsening, you can add Clinda, and that can be given kind of as a 1 milligram dose weekly. Those are kind of the indications. The ones I would obviously avoid is if anybody is potentially immunocompromised, or if it's a primary toxoplasmosis presentation, then obviously you're worried about circulating systemic circulating disease, and so you want to treat it with oral treatment as well. Sorry about that, Yusuf. If you could just start that over again. This is an interesting case. Look forward to it.
Yep, no problem. All right, so let's go on to case 4 here. So case 4 is a 86-year-old man, Caucasian man, who's referred for bilateral necrotizing retinitis by his ophthalmologist, and he had complained of a 3-month history of right greater than left decreased vision and floaters in both eyes. His past medical history was significant for prostate cancer, although he was in remission, and he had been placed on Valtrex 2 grams 3 times a day and Durezol 4 times a day for suspected viral retinitis dosing. This has been on place for about 3 weeks by this point that we saw him. On exam, the visual acuity was 20/50 in the right eye and 20/60 in the left eye, and the pupils were normal. The pressure was also normal. The anterior segment exam demonstrated some fine KPs in both eyes and 1+ anterior chamber cell in both eyes. And as I mentioned, the patient was pseudophakic. So here in the posterior segment, you can see 2+ vitreous haze in both eyes with vitritis and large area retinitis nasally in the right eye and then temporally in the left eye. So this is a bit concerning here. The discs appeared pretty normal. There was no significant lesion in the macula. I think that opacity there in the left eye is just some artifact. The patient was felt to have bilateral presumed acute retinal necrosis, and they were given intravitreal ganciclovir 4 milligrams per 0.1 cc's in both eyes. They were told to continue on their Valtrex 2 grams 3 times a day and their steroid, and a uveitis workup was sent. The patient was then told to follow up in 3 to 4 days to repeat intravitreal ganciclovir injection. A comprehensive uveitis workup was done and didn't really yield much. The AC tap was negative for viral PCR, although the antivirals had been started 3 weeks prior to this. So even though they were negative, it was still felt that we were dealing with a viral acute retinal necrosis at this point. The patient over the next 3 weeks received intravitreal ganciclovir injections 2 times a week, but there were no significant changes. So they were changed to intravitreal foscarnet 2 times a week. 6 months after they initially saw us, they had a bit of an improvement in the vitreous haze with the retinitis slightly regressing in both eyes. So there was a bit of a response to the foscarnet. So at this point, we thought that the retinitis was stabilizing. The interval of injections was decreased to once a week, and they were dropped down to Valtrex 1 gram daily for a prophylactic dose. They were also added on Acuvale 2 times a day for a bit of CME that they had. 6 weeks after this, the foscarnet interval had been decreased and stopped for the past week prior to this, but there were new areas of retinitis in both eyes. So the patient was unfortunately had a reactivation of the retinitis, and they were restarted on the 2 times a week intravitreal foscarnet protocol. They were put back on the full dose for the Valtrex 1 gram 3 times a day, and they were referred to a uveitis specialist. 2 months after this, the patient was on the intravitreal foscarnet injections 2 times a week, and there was a little bit of an improvement, but maybe not 100% what we'd expect. But we are still comfortable, not necessarily happy completely, but the retinitis was at least getting worse. So the interval of the foscarnet was dropped down to once a week. Valtrex was also dropped down to the prophylactic dose, and a repeat AC tap was done, which is actually positive for HSV2 on the PCR. So we thought we had our diagnosis of a viral acute retinal necrosis at this point. I'll just fast forward a bit over the next 12 months. So over the next 12 months, this patient had a relapsing and remitting disease course with times of worsening retinitis and also improving retinitis. And this was maybe corresponding with when the intravitreal foscarnet was stopped and restarted, but wasn't absolutely necessary coinciding with these timeframes. Repeat AC tab was done and it was negative for the viral PCR. Roughly 17 months after presentation, and despite multiple cycles of the intravitreal foscarnet and oral antiviral coverage, you can see here that the patient was seen with significant recurrence of the retinitis, more vitreous haze. There was a big area of retinitis temporally in the right eye. So we were a bit questioning what was going on here and whether HSV2 ARN was really the right diagnosis in terms of what was going on. So another AC tab for viral PCR was done. It was negative. The patient actually underwent a diagnostic vitrectomy with a membrane peel for an ERM that they had, and the vitreous sample for the viral PCR was negative. Cytology was negative. Fungal cultures were negative, just thinking about masquerade syndromes, and they even went an MRI brain, which was normal. One of the last things we did was we sent off for a toxo IgG and IgM and did an AC tap for toxo PCR. And the toxo IgG was positive initially for the patient on the onset of this case when they were referred, but because of the clinical picture, we felt that it was ARN. So an IgM and a tap for the PCR were not pursued. And to our surprise, the IgM and the IgG actually came back reactive, as did the positive result for the aqueous toxo PCR. So this supported actually toxo as a diagnosis as to what was going on. Treatment was started for toxoplasmosis with Septra double strength 2 times a day, and the patient was restarted on Valtrex for prophylactic dosing just because of the positive HSV2 diagnosis before. And if the patient was improving, we were planning to just stop the antiviral with continuing with toxo treatment. So just to reorient yourselves here, after before the toxo treatment was started, there were these large areas of retinitis in the right eye with a lot of vitritis. And then 2 months later, you can see significant clearing of the vitritis and also some improvement in the retinitis. And then if we jump another 4 months later, you can see complete quiescence of the retinitis with much improved vitritis furthermore. So the patient responded extremely well to the Septra. They were not in any antivirals over the past 4 months. The vision was 2200 in the right eye, 2030 in the left eye, but they underwent a vitrectomy in the right eye, so we're awaiting silicone removal. That's probably the reason for the decreased vision. So great response to the Septra and the toxo treatment after the IgM, IgG, and the toxo PCR came back positive. To just summarize the case, there was a kind of a long progression here, but overview is that they were referred as acute retinal necrosis. An initial AC tap was negative for HSV. They did not have much of a great response to the intravitreal ganciclovir. Same with the foscarnet. A repeat AC tap was positive for HSV2, but negative afterwards, including a vitreous sample. And then at some point, the toxo IgG and IgM were done and positive, as well as a toxo aqueous PCR. Once they were started on toxoplasmosis treatment with the Septra, they responded extremely well with resolution of the retinitis. So going back to what was really going on in this case, it was a bit of a difficult clinical picture. You know, was this toxo or was this HSV2 ARN? One option is that this was really a viral resistant retinitis. And, you know, the patient did have a positive HSV2 PCR, but was negative 2 times after. It was also negative in the vitreous sample from the vitrectomy, and they didn't really respond much to the antiviral treatment. What we think was really the case was that the patient had fulminant multifocal toxoplasmosis, and the IgM and the IgG certainly supported this diagnosis. The IgM corresponding to a recent/active infection, the IgG corresponding to a chronic infection. And then the serologies were supported by the toxo aqueous PCR. The patient also responded extremely well to treatment. So I think that kind of gave us diagnostic certainty. And really the patient's retinitis improving, waxing, waning, fit the clinical picture of toxo. So it's possible that the patient may have just been getting better, regardless of whether they were on antivirals or not. And the improvement when they were on antivirals may have just been a red herring. Lastly, it maybe was a thought that this is a combined etiology, but this is extremely rare. And I think the response to toxo treatment kind of gave us the clinching diagnosis. To
So
move
this
on,
is this was a really tough case just because of how it presented. You know, he presented with bilateral, which again, unusual for toxo, bilateral primary, and never had a previous history of toxo. They're both large areas of retinitis anteriorly, like near the aura, similar to what you'd see with acute retinal necrosis. And you have to be always careful about attributing success of treatment when the natural history of something is waxing and waning. And kind of the analogy I'll give is what I call the tic-tac analogy with CSR, which is, you know, a patient comes in with CSR and you say to them, you have CSR, I've got a really good treatment. It's the only one that works. It's those orange tic-tacs. You give them a box of orange tic-tacs. You say, take this every day for the next 2 months. Patient comes back 2 months later, subretinal fluid's gone. You say, see, I told you that those Tic Tacs work. Stop the Tic Tacs, they're working. They worked, you're all done. Comes back 3 months later, he's got fluid again. You say, hey, pull out those Tic Tacs again, they're gonna help you. You give him the Tic Tacs, 2 months later, it's gone. Stop them. So not only are you having response to the treatment, but you're having recurrence when you stop it. So you really are convinced to yourself that these Tic Tacs are working. Well, it's the same for this. This guy, you know, he was receiving injections. Initially, they thought, oh, maybe he has antiviral resistance, so they switched to foscarnet. When they switched to foscarnet, you know, his retinitis started to go away. They increased the dose or stopped the foscarnet, it would start coming back again. You start the foscarnet, retinitis burns out, feels better, you stop it. And so you kind of get into this picture where you're starting and stopping things at the same time as the natural history because you're tailoring your treatment based on the response. And so you're thinking that you're having success when really it's the natural history of the disease. So that's kind of something that we just need to take into account whenever we're treating people. So, okay, Yusuf, you can continue.
sure. So, that was our case. We'll just move over into the case discussion here. So this patient had what we call fulminant multifocal necrotizing toxoplasmosis, and this is a rare presentation of toxoretinitis, which clinical features include uni or multifocal large areas of retinitis. It can be in one eye or both eyes, oftentimes rapidly progresses, but also waxes and wanes in severity, as Dr. Tristakis mentioned, as far as the natural history and progression of toxo. Retinal detachments are not uncommon, although our patient did not detach in this case. Risk factors for fulminant necrotizing toxoplasmosis are mainly surrounded around immunosuppression. So immunosuppressed states like HIV and AIDS, malignancy, but especially steroids are commonly implicated in this phenotype of toxoplasmosis. In fact, there have been cases of patients who are misdiagnosed as non-infectious uveitis, then given local steroids, and then develop fulminant toxoretinitis. So always extremely important to make sure that you know if you're dealing with an infectious etiology. And we'll move into kind of the differential for a necrotizing retinitis later on, but very important to rule out infectious causes here because it can get worse if it is a fulminant necrotizing toxo. And then, of course, age. This phenotype of toxo is almost exclusively reported in elder individuals, as in our case. And if you think about it, age is also just like a relative immunosuppressed state. So this does make sense to a certain degree. There is a differential for necrotizing retinopathies, and this may be not completely exclusive, but these are kind of the ones that come to mind when you have a patient that walks in the door with large area retinitis. And kind of starting off with acute retinal necrosis and progressive outer retinal necrosis, we thought the patient had this initially, and it was quite a difficult case. There's CMV retinitis, syphilitic retinitis, toxo, as we had in our case, masquerade syndromes like vitreoretinal lymphoma, endogenous endophthalmitis, fungal and bacterial, and Behçet, so autoimmune conditions as well. And while these all have maybe their own clinical phenotype, it can be hard to differentiate these from one another. So let's say a patient comes from the emerge, walks into your clinic with a necrotizing retinitis. It's useful to have an approach to kind of have a starting point on how to deal with this. So of course, with any uveitis, it starts with a history and a review of systems, head to toe, constitutional systems, risk factors, and so on and so forth. It's important to conduct a full uveitis workup with your run-of-the-mill, syphilis, TB, sarcoid, ruling out infectious causes. But really, one of the highest yield tests here, most important, is the AC-TAP for viral PCR. You can also include toxo in there, and then serologies for HSV, VZV, other posterior uveitis like Bartonella, and toxo. And if a patient comes in and they have this presentation and they don't have any clear risk factors, maybe they're a bit younger, it may also be worthwhile to rule out immunodeficiency with HIV. You'll probably see something on the differential that you get with a CBC, but just a good idea to keep this in the back of your mind. And then if indicated based on the history that you take, you can always get an HLA-B51 if they have genital ulcers, or you can do an SPEP and MRI if they have maybe malignant features, and then blood cultures if you're suspecting an endogenous cause. For treatment considerations, if a patient's truly undifferentiated and you're not really sure what could be going on, it's useful to think of the worst possibilities. And for that reason, starting empiric antivirals at acute retinal necrosis dosing with Valtrex 2 grams 3 times a day, or oral or IV acyclovir if they're admitted, is a good starting point. But you can also start Septra at the double strength BID dosing in case you're not 100% sure whether it's a viral or a toxo case. Some case reports have actually reported starting both of these medications, viral and toxo treatment, because of the undifferentiated nature of these cases. And then intravitreal antivirals with ganciclovir and foscarnet, possibly antibiotics if you're suspecting a bacterial cause, can also be done empirically while you're waiting for investigations. And then once the investigations have fully come back, you just tailor your treatment. So if toxo is confirmed, it's important to continue the toxo treatment. For example, with Septra, the antiviral can be stopped, and you can use adjunctive oral steroids, intravitreal Clinda or intravitreal dexamethasone. And then, let's say if you have an ARN, you just stop the Septra, continue the antiviral, and give intravitreal ganciclovir, foscarnet injections every 2 to 4 days until the retinitis is clearing. I'll just finish off this case with a couple other pearls for necrotizing retinitis. Serial optos photos are very, very useful to document changes. And as you can see here, we took a lot of photos, not just to present the case, but also just to document whether there's any improvement or worsening of the retinitis. Because sometimes, it can be hard to remember what a patient has looked like before. It's useful to have a picture of what they look like, and then you being able to compare just to see if they're responding to treatment. It's important to counsel on the risk for retinal detachment. We know there's a pretty high prevalence of retinal detachment in ARN cases, but also not insignificant amount of retinal detachments in toxo that Hib also just presented earlier in the grand rounds. And then kind of a key learning point from this case is that you should really have a low threshold for repeating the AC-TAP or vitreous biopsy or other investigations if the patient's not responding to treatment as expected, or if you don't have a diagnosis yet. So these are just some pearls. I'll leave it home to Dr. Tristakis to kind of go over some take-home messages and summarize the grand rounds.
Okay, so that was an amazing case presentation, Yusuf. Thanks so much. There's a question in the audience. How soon after a negative AC-TAP PCR would you recommend a vitreous tap when the AC-TAP is negative, is significantly more sensitive relative to AC-TAP, and worth it when the suspicion is high and not responding to treatment? Okay, it's a great question. I think that in AC-TAP, it's very sensitive for viral retinitis. Like the sensitivity is 90 to 95%. If somebody has a negative AC-TAP, I think my next, and I had a high index of suspicion for viral, I'd probably repeat the AC-TAP. I don't think that a vitreous tap, like done in the office, improves sensitivity significantly. And I think it's sometimes hard to get a vitreous tap for 2 reasons. One, you get occlusion of the needle from vitreous. And also you might actually induce vitreous traction. So there's a little bit more morbidity associated with it. So I would repeat just an AC-TAP if the first one is negative. The tough thing about this case was you know, they were attributing the AC tap. The AC tap was always done after antivirals were started. They were started for several weeks before the AC tap. So people thought maybe the reason why it was negative was because they were on treatment. And then when the treatment was all stopped and the AC tap was repeated, they had a positive HSV2, which was, you know, quite convincing. You know, you have a positive test, you think you have a diagnosis, but you know, the specificity isn't 100%. I mean, it's pretty high, like I'd say in the 90s, but definitely not 100%. So this one thing that was a bit unusual for this case is that he had a negative HSV2 IgG. So you can interpret that in two ways. You could say, well, if he had a negative IgG, then it's very unlikely that he has HSV2 in the eye. Or you can interpret it the way we did, which was, well, if he has a negative IgG, it means he's not posting an immune response to it, which is probably why he's continuing to recur when the antivirals are stopped, because he's not able to fight off this HSV2 infection. So this particular case was a bit unusual because it was complicated in many ways. It was kind of the perfect storm of a waxing and waning course with a false positive, and you know, bilateral disease, started with anterior involvement. Obviously, these are quite rare cases, but it's just a reason why we should always keep tox on the differential. And here's a great example where IgM is super helpful. He had a negative IgG, but you know, IgM remained positive, because while IgM usually goes up and then goes back down, if you have untreated disease and you keep having a waxing and waning course, when you initially reactivate, your body produces IgM. So you have multiple spikes of IgM over the disease course. So when we sent off the IgM again, then the IgM was positive, and that is basically, you know, indicative of an active toxo infection. So you don't have to do a PCR because it's oftentimes very difficult to get, and they need a large sample. So oftentimes you have to dilute it with BSS so that they can process the sample. But you know, getting an IgM, I think, is something worth considering, especially in these challenging cases.
Panos,
Yeah.
in the anterior segment, it's about 90% of immune competent hosts will only have unilateral disease. Does that change in the retina? Does that factor into your forming your differential if you see it bilaterally?
I mean, bilateral versus unilateral, like if somebody's immunocompromised, you're obviously more likely to get something bilaterally. Whenever you see something bilateral, you think of something that could be systemic, right? You know, either something like an endogenous. This patient, quite early in his disease course, we were worried about vitreoretinal lymphoma, given the multifocal areas of retinitis, and he underwent a vitrectomy with a chororetinal biopsy. That's why he had oil in the eye. So I think that when something is bilateral, you obviously think of systemic diseases or certain infections, either endogenous or viral, that you think of more.
Would you think it's less likely to be HSV or HZV if it's bilateral in the retina? I know we would factor that into our equation.
I mean,
the cornea.
bilateral acute retinal necrosis is significantly more rare than unilateral retinal necrosis. So I think that it probably reduces your index of suspicion if it's a bilateral process. But we go, you know, for the retina, we go more based on clinical appearance rather than, you know, the diagnostic testing. Because as you know, for serologies for viral, they're not very helpful at all, because we're all, you know, 20 or 30% of the population may be positive for certain, depending on what infection it is, and higher for things like zoster, you know, everyone's going to be positive. But yeah, I think that bilateral obviously warrants more of a systemic workup, and it's affecting both eyes, so the stakes are a lot higher as well. Okay, so let's go through take-home messages. So the first one is, an atypical presentation of a common disease is more likely than a typical presentation of a rare disease. Just statistically, this is true. You always have to think of the common things, like, you know, I kind of inherited this case halfway in, but it did take me a while to reassess and to really think about toxoplasmosis as an etiology, because it wasn't a typical presentation. But, you know, first thing I should have thought is, well, what are the common things that cause bilateral retinitis? And although toxos not usually doesn't, it's a common disease. So just statistically, common diseases tend to be more likely than rare ones. Now, we went through the phenotypic presentations. focal retinal choroiditis with vitritis, by far the most common. If you see that headlight in the fog appearance, you should treat it empirically for toxo. Drawing an IgG is great because if it comes back positive, you're still on the right track. If it comes back negative, then you're probably on the wrong track. So it's not a confirmatory test, but rather one that may direct you otherwise if it comes back negative. Not helpful if it comes back positive. Diffuse vasculitis. This is an interesting one because that gentleman that you saw with the choroidal lesion and the vasculitis, I've seen probably a dozen of patients that are almost similar to that, and it has that classic appearance of vasculitis that is sectoral and is quite profound, not in keeping with the clinical picture. So always think about toxo when you have that. In terms of the port variants, any toxo that's in the macula and doesn't have vitritis, you obviously have to think about port. The fulminant multifocal involving one, that again is rare, but think about it in people that are older and that are immunocompressed. Immunocompromised, and then the punctate interretinal toxo, where you see focal areas of punctate interretinitis. So what are the investigations? So you can do a basic uveitis workup. Oftentimes, what's helpful, people are saying, well, why are you getting TB? Why are you getting syphilis? Sometimes it doesn't look like TB or syphilis, but we oftentimes will get it because these people will be started on systemic steroids and oral prednisone, and you want to make sure you're not reactivating something. So that's oftentimes why we'll get TB testing, even if it doesn't have a classic appearance for TB or risk factors. TB obviously could present as a choroidal granuloma with associated inflammation, so sometimes it can mimic it. In terms of serologies, again, systemic serologies are helpful in ruling things out, but a lot of people that are not affected will have positive HSV1 and 2, so it's not specific, but it's quite sensitive. If it comes back negative, it's probably not that. AC TAPs, again, very important to rule out viral etiologies because the sensitivity is very high and the specificity is very high. If it comes back negative, consider retapping. And low threshold to repeat investigations if are negative or it's not responding to treatment properly. And then one masquerade that you always have to think about is primary vitreoretinal lymphoma because it can sometimes present this way, as well as endogenous endophthalmitis or you can get choroidal Mets, but obviously that usually looks different. Then in terms of the treatment, there's the classic triple therapy. For a long time, pyrimethamine was extremely expensive and hard to get. So I think most uveitis specialists have tended away to that. Most people will start Septra as the first line. I'd say definitely Septra is the most common first line agent, Septra double strength BID. And then if anything is macula or optic nerve threatening, I start clindamycin as well. So they get both Septra and clindamycin. Clindamycin being 300 QID and the Septra's double strength BID. And then you can also add local therapy. Azithromycin is for people with allergies. I have another patient that had fulminant multifocal toxo, similar to this case, that had a severe full body rash with Septra and has been on azithromycin and doing well. In terms of steroids, when to use them, if there's severe inflammation, vitritis, or vasculitis, those are all reasons to do them. Or if you're worried about optic nerve or central macular involvement, it's worth considering steroids. Most people will wait 48 hours to start them. And then in terms of empiric treatment for viral retinitis and toxo while awaiting investigations, I'm not one to recommend kind of a shotgun approach, but I think that, in cases where something is vision threatening and you're really not sure what's going on, I think that Valtrex and Septra have relatively safe profiles. And if something is potentially vision threatening or bilateral, I think it's very reasonable to start empiric treatment while you're waiting for your tests to come back. Oftentimes it's only a couple of days. And so this is a summary of the cases just showing how they kind of look differently. Thanks everyone for your attendance. There's one other question, which is from Mirna Lichter. What do you advise to someone outside an academic center? Is PCR available province-wide? Toxo PCR should be available at many hospitals in terms of being able to run that. The question is about samples. So our hospital requires 1 cc sample to run the test, and you can imagine 1 cc is impossible to get with unless it's a vitrectomy specimen. So oftentimes what I'll do is I'll do as generous of a AC tap as I can to try to get 0.2 to 0.3 cc's. And then we have the lab dilute it to 1 cc so the test could be run. That probably reduces the sensitivity slightly, but I've definitely had positive toxo on several occasions. So it is a kind of a helpful test. I think when you're getting to the point where you've exhausted all your options and the patient's going for a vitrectomy, then obviously the sensitivity will be much higher for a vitrectomy specimen. But it can be done with an aqueous sample. It's just a matter of checking with your hospital. Good job, Heba and Yusuf. Great summary and discussion. Thanks everyone for your attendance, and I guess we'll reconvene next week for grand rounds.
Great job, Yusuf and Heba. And Panos.
Thanks. Take care, everyone.